Hello, good morning, everyone. This is Dr. Eric Bricker, and thank you for watching A Healthcare Z. Today's healthcare finance training session is on underutilized care. So thank you so much for joining. If you could, as usual, leave a comment either on LinkedIn or YouTube to let me know that you can see and hear me okay. That would be super helpful. And also know, as we go through this presentation, please put your questions and comments in the comments, again, on LinkedIn and YouTube as well. And I will answer those either as we go along or at the end, or I'll answer them back in writing. And so with that, I want to do a brief introduction of myself for those of you that don't know me. Many of you do know me. I am an internist. Before I went into to medicine, I actually used to be a hospital finance consultant at major medical centers, and then went to medical school at the University of Illinois at Chicago, and then did my internal medicine residency at Johns Hopkins in Baltimore. And I worked as a hospitalist physician in a suburb of Dallas. It's called Plano, that you might be familiar with. And I actually started a healthcare navigation company called Compass Professional Health Services that helped people navigate their health insurance and all the different, doctors and ologists. And we grew that to over 2,000 employer clients because people would get access to our service through their job. And we supported 1.8 million people, literally from Seattle to Miami and everywhere in between. And eventually sold that business in 2018 to Alight Solutions. So Compass doesn't exist anymore. It's actually the navigation solution within Alight, which is a huge benefit administration company, over 10,000 employees. And then I worked with so many HR leaders and brokers and benefits consultants and CFOs and CEOs when I was at Compass. I'm like, hey, there's still this misunderstanding of how the US healthcare system works. So I will make these A Healthcare Z videos to continue sort of educating folks around that. And so my A Healthcare Z videos, believe it or not, I think I had like 2 million views across LinkedIn and YouTube last year in 2022. So thank you to all of you for watching those videos. And I'm now also the medical director for Simple Pay Health, which is an alternative health plan. Now, on to today's topic of underutilized care. The entire theme of today's conversation is around an ounce of prevention. So when it comes to employee health care and our own individual health, an ounce of prevention is worth a pound of cure. I'm sure many of you know that expression from Benjamin Franklin and Poor Richard's Almanac. And so specifically, as it relates to cardiovascular disease and stroke, and we're going to get into mental health later on in this discussion as well, that what's driving so much of employee poor health and high healthcare costs are catastrophic claims, right? We've talked about this many times, and it's claims over $50,000. And those claims over $50,000 tend to be in cardiovascular disease, they tend to be in cancer, and they tend to be in musculoskeletal. And so we're like, hey, we need to do something about these high cost claims, especially for cardiovascular disease. The time to do something about those high cost claims is not when the high cost claim is occurring. It's not through case management. It's not through utilization management. It's not through prior authorization. The way to address cardiovascular disease is at the beginning with prevention, with an ounce of prevention worth a pound of cure. Because once extensive cardiovascular disease has set in, it's super hard to do anything that's not incredibly invasive and high cost about it. Okay, so you have to address it up front. Now, what I have on here is that obviously, number one, heart disease is the number one cause of death in America. And interestingly, I've talked about William Osler in the past as well. He was the founding medicine physician at Johns Hopkins back in the early 1900s. He said the key to longevity is in the vessels. So you want to know the secret to a long life? You want to know the fountain of youth? Shoot, Dr. William Osler identified it over 120 years ago. It's in our blood vessels. Okay, so keeping our blood vessels healthy is super important. And again, because cardiovascular disease is one of the top 3 diagnoses for high-cost claimants for employer-sponsored plans. Now, it's in 7% of US adults. There are 800,000 heart attacks per year. And interestingly, there are almost as many ischemic strokes. So this process here, these pictures here of what is referred to as atherosclerosis, or narrowing of the arteries, right? So there you've got an artery, and there it's just starting to get narrowed a little bit, and there it narrows some more, and then it completely gets blocked off. And when it completely gets blocked off, the lack of blood flow downstream is referred to as ischemia. That is what ischemia is. It is a lack of blood flow. So ischemia of the heart is called a heart attack, or a myocardial infarction, or an MI for short. And ischemia in the brain is an ischemic stroke. So the process of a heart attack and the process of a stroke are exactly the same vessel event. It's the exact same vascular event. It just happens that one is happening in the heart and one is happening in the brain. And so the way to prevent both is exactly the same. So, why I call this training session underutilized care is because preventing cardiovascular disease actually does not fall under what is quote unquote preventive care that is covered at 100% by your health insurance. So there is gobs of health care that is quote unquote preventive. In other words, preventing cardiovascular disease that still falls to deductible, still falls to coinsurance. If you've got a copay plan, it still falls to your copay. So there are still patient out-of-pocket costs, sometimes very large patient out-of-pocket costs. Relatively large. I mean, large for them. I mean, $500, $1,000, $2,000 for a patient, right? That's a lot of money for an individual, right? And all these things are necessary, oftentimes underutilized care to prevent heart attacks and strokes. What are those areas? Well, they're the risk factors for cardiovascular disease: hypertension, high LDL cholesterol. So LDL stands for low density lipoprotein. That's the bad cholesterol. Diabetes, smoking, obesity, and inactivity. Okay, so those are the main risk factors for cardiovascular disease and ischemic stroke. Now, to diagnose and treat these things is not preventive. It is not dictated by the Affordable Care Act to be covered up at 100% by the health plan. So by definition, there will be a cost share to the employees. And that cost share actually acts as a barrier to this underutilized care. So to a certain extent, the existing plan designs today discourage the preventive care that averts high-cost claimants for cardiovascular disease and stroke. Now, all these areas of hypertension, high cholesterol, diabetes, smoking, obesity, and activity, they're also the domain of primary care. Like, who screens for these things? Who diagnoses these things? Who treats these things? It is by and large the primary care physician. So you've heard me talk a gazillion times about why primary care is so important. But it's not just about using quote unquote primary care. It's not about using less care de facto. Using primary care is actually about using more of certain types of care. And so we're going to continue to talk about more care for hypertension, more care for high cholesterol, more care for diabetes. Okay? So first up, hypertension. 75, oh, by the way, all these stats come from the CDC, and I've got a slide at the end that has all the stats as well. If you want the slides, just email me at the end. I'll give you my email address. Okay, so 75 million Americans have hypertension, completely silent disease, right? Known as the silent killer. What's 75 million Americans? It's 30% of adults. Okay, so it's not 30% of the US population, but it's 30% of adults. Okay, half of people with hypertension do not have their hypertension controlled. Additionally, 11 million out of those 75 million, which is 15%, 11 divided by 75 is 15%, are completely undiagnosed. You can walk around with hypertension for decades and never know it. And so fine. So if 15% are undiagnosed, but half are not controlled, that means that there are gobs of people with hypertension who've actually been diagnosed and their hypertension is still not controlled. They're seeing a doctor, their high blood pressure is not controlled. Why is that? So, lucky for all of us, that's actually what I did my research on during my residency. And it turns out that 70% of patients with hypertension require 2 or more medications to effectively treat their hypertension. So I would see a patient with high blood pressure and, first time seeing them, and they would be on one blood pressure medication. And I'm like, aha, there's a 70% chance that you do not have your blood pressure controlled because it's highly likely I'm going to have to add a second blood pressure medication. So, and this is true for patients too. They're like, well, I'm taking my blood pressure pill. That should be enough. And the answer is 70% of the time, it's not enough because you need 2 medications. Oftentimes it's 2 different types of medications that control blood pressure in different ways that work synergistically to effectively control the high blood pressure. And I'm just going to go through some of these different categories of high blood pressure medications. So one is called hydrochlorothiazide. It's just abbreviated HCTZ for short. That is a diuretic. Another one is called lisinopril. That's an ACE inhibitor. Then another one is called amlodipine. That is a calcium channel blocker. And another is called metoprolol. And that is a beta blocker. And all 4 of these are in different categories of blood pressure medications. And so combining 2 out of these 4 is super helpful. So you might do and guess what? They make combo pills of hydrochlorothiazide and lisinopril combined. They make combo pills of hydrochlorothiazide and metoprolol combined. And all of these medications are generic. You can get for $4 a month or less than $4 a month. Oh, by the way, the combination medications are also generic. So you don't even have to pay 2 $4 copays for 2 generic medications. You can pay one $4 copay for a combined hydrochlorothiazide, lisinopril, or so I see someone in the comments just wrote losartan hydrochlorothiazide. That's another medication. That losartan is referred to as an ARB, right? So there's even a 5th class on here. The point is that there's over 80 different blood pressure medications to treat high blood pressure. There is no reason why somebody's high blood pressure should not be controlled. We got the tools to do it. And oh, by the way, the vast majority of those 80 blood pressure medications, generic, hugely cheap. Okay. So I love, as you can tell by my passion, I love treating hypertension. Most doctors hate treating hypertension because it's so boring. Man, I love treating boring stuff. Okay. Because that's the ounce of prevention that's worth more than the pound of cure. Okay. Next up, high cholesterol and diabetes. Okay. High cholesterol. Even more adults have high cholesterol. 100 million adults in America have high cholesterol. That's 40% of US adults. Half of them are untreated. So by definition, if they're untreated, they're uncontrolled. So high cholesterol is a hugely undertreated condition in America. Okay. Diabetes, 34. Now, diabetes is, you see ads for diabetes medication. We talk about it constantly. Diabetes, right? And 34 million Americans have diabetes, both type 1 and type 2. The vast majority have type 2 diabetes, which is mostly associated with insulin resistance and obesity. That's 13% of Americans. And look at that, 21% of people with diabetes are not diagnosed. I had a good friend of mine from high school who was diagnosed with diabetes around the age of 40. And he had gone in like 5 years before and for something. And they did a basic metabolic panel and his glucose was elevated. And the doctor's office was like, yeah, your glucose was a little high, but nothing was ever done about it. So he had not received a formal diagnosis. He'd never been worked up for it. He never got a hemoglobin A1C. He walked around with diabetes for 5 years, undiagnosed. He was part of the 21%. Okay, and who knows? He might have even had it before he was 35 when they did that blood sugar. Okay, next up, 26% of diabetics are adequately treated for their diabetes, their hypertension, their high cholesterol, and their smoking cessation. Because if you have diabetes, you need to have your hemoglobin A1C. And this is only less than 8. It's not even less than 7. Okay, so 75% of people with diabetes have their hemoglobin A1C less than 8. Okay, and then 70% of diabetics have their blood pressure adequately controlled. And then 66% of diabetics have their high cholesterol adequately controlled. And then 86% of diabetics are non-smokers. But when you overlap all of those together, of all the things they should be doing, only a quarter of people with diabetes are actually being effectively treated. We have not, like, oh, you've got diabetes. All of these people are under the care of a doctor, right? Only a quarter of people with diabetes are being effectively treated, okay? Like, that's a travesty. The fact that only half the people with high cholesterol in America is a travesty. And for you, if you're a broker or you work in HR or you are responsible for an employer-sponsored health plan, you are a population health manager. You are in the business of public health, and you have huge clinical risk within your population for hypertension, high cholesterol, and diabetes, and they're all silent. And all of this risk, like, you're like, well, we're looking at our claims. Shoot. The vast majority of that risk is not in your claims, but it's there. And where does it show up? It shows up as your high-cost claimants. And you're like, wow, we're getting all these high-cost claimants for peripheral vascular disease and for heart attacks and for strokes and for ICU cases. What's going on? This is what is going on. Okay. The treatment. So again, you hear so much about diabetes because there are brand name treatments for diabetes that are very expensive. So the pharmaceutical industry does tons of promotion around diabetes, right? Guess what we used to do tons of promotion around? High cholesterol. Why? Because Lipitor and Crestor were on patent, and Lipitor was the #1 selling medication in the world, and it made Pfizer billions of dollars. And then Lipitor went on off patent. It's called atorvastatin, and as soon as it went off patent, all the ads stopped, all the awareness stopped, all the public concern about high cholesterol stopped because they couldn't make any money off it anymore. Well, guess what? High cholesterol is still a huge problem. It's not a problem anymore. It's just because the medical industrial complex can't make as much money off of it anymore, so they don't talk about it. It's still a huge deal. It's treated by these statin medications, atorvastatin, which is generic Lipitor, simvastatin, which is generic Zocor, rosuvastatin, which is generic Crestor. These medications are highly effective. They're incredibly safe. In the UK, you don't need a prescription to get a statin. You can just walk into a drugstore and be like, yeah, my doctor diagnosed me with high cholesterol. I can just walk into the drugstore and I get Tylenol and I can get my atorvastatin to treat my high cholesterol. In America, we need a prescription, but in other countries, you don't even need a prescription. Okay, and then for diabetes, first-line therapy is metformin. It's the most commonly prescribed medication for diabetes. Again, it's all generic. This is all generic, $4. Metformin, generic, $4. The sulfonylureas, which have been around a long time, also very effective for treating diabetes. Glipizide and glyburide, $4. Guess what? They make a combo pill of metformin and glipizide. $4 for 2 medications together. So you can take 4 medications, 2 blood pressure medications and 2 diabetes medications, and you only have to take 2 pills, like once a day. You don't even have to take them twice a day. So it is hugely cost effective and easy to do it, yet it is not done. Okay, now, and we're going to get into the end as to why that is. Okay, next up, depression. Okay, so now we talk about a completely separate area of underdiagnosis and undertreatment, and that is depression. Because ultimately, you as an individual, me as an individual, all the employees and their family members on the employee health plan, if you have depression, it's very difficult for you to think straight. So having depression isn't just about having a depressed mood or feeling sad. It has huge implications for lack of motivation. It has huge implications for difficulty with memory. It has huge implications for difficulty with just cognition, with being able to do critical thinking. And guess what? If you treat the depression effectively, your memory improves. Your motivation improves. You're like, I'm not really motivated. I'm just sitting around on the couch all day. Well, guess what? It's not because you're lazy. It's not because I'm lazy. It might be because you're depressed. I mean, it's a clinical illness. It's not like you're not a bad person. Like, it's not a question of moral laxity, of sloth. Like, we have not had this sort of epidemic of moral collapse and sloth in America. Like, you're depressed. Okay? Now, pre-pandemic, 8.5% of US adults were depressed. Now, post-pandemic, that number is 29% of adults. Okay, that's right. This is according to a Boston University study. Okay. It has increased 3x. It's almost a third of US adults. So you look around your company, you look around your peers, right? People don't have a sign on their forehead that says, I'm depressed. People don't walk around talking about their depression all the time. But you got 10 people in your office, it's a small company, it's highly likely that 3 out of those 10 people are depressed. Again, largely undiagnosed and untreated, silent, okay? Survey of 200 adults, of those with no diagnosis of depression, 32% were found to be depressed upon screening. So just because you don't have a diagnosis of depression, that doesn't mean you're not depressed, which is why depression screening is part of the U.S. Preventive Services Task Force recommended screenings. So you're like, okay, we got to do our screenings. We got to do our mammograms and our colonoscopies and blah, blah, blah. You have to screen for depression. And you're like, oh, I'll just do it during my physical exam. That's not how it works. You don't like wait for someone's annual exam to screen for depression. Like when they come in for their sinus infection, you screen them for depression. When they come in for their low back pain or their sprained ankle, you screen them for depression, right? So you've probably heard me say this before. All primary care physicians, for every visit, they do something called RHM, which is routine health maintenance, which means that, hey, you didn't come in for this particular reason, but it's my job as a primary care physician to be proactive about your routine health maintenance, which includes a screening questionnaire for depression. And you don't just do it once, you have to do it repeatedly because your life and your life stressors change, okay? And then by going to the primary care physician, you can treat it. You can treat it, okay? There are so many medications and tools to treat depression, okay? You've got the entire class of selective serotonin reuptake inhibitors, SSRIs, fluoxetine, which is the generic name for Prozac, escitalopram, which is the generic name for Lexapro, and sertraline, which is the generic name for Zoloft. There's many others. These are 3 of the more common ones, okay? I'm going to give you specific indications for why these are used. Prozac is great because it has what's called a really long half-life, which means that if you forget a dose, it's not a huge deal because the Prozac sticks around in your system. So it actually, all these medications, it takes a while to build up in your system. So it takes like a week to 2 weeks for actually to get a sort of a stable level of the medication in your bloodstream and for it to have an effect in your brain. And so like I just told you, people with depression have a hard time thinking. What does that mean? They have a hard time taking their pills, which is why if you put a patient on depression and they miss a pill, it's not a huge deal because their blood level of the fluoxetine doesn't go down that much. And so you're like, oh, I don't remember if I took it or not. I don't want to take 2. I'm freaking out. Like, it's okay. Just like take one tomorrow. It's easy peasy. Okay. And then Lexapro has some indication that it actually has some degree of greater efficacy than the fluoxetine or the sertraline or the other SSRIs. So sometimes people are put on Lexapro because it's a little bit more effective. And then sertraline is used because it's been found to be safe in pregnant women. So a lot of people either have depression during their pregnancy or they have postpartum depression. And Zoloft, sertraline is really the antidepressant, the SSRI of choice for OBGYNs. Very safe in pregnant women and new moms. Okay, next up, the serotonin norepinephrine reuptake inhibitors, which work on both serotonin and norepinephrine in the brain, have actually been, again, found as a class of medications to be slightly more effective than the SSRIs. So again, generic name venlafaxine, brand name for that is Effexor, generic duloxetine, brand name Cymbalta. They're all generic now. Again, you can get these for like $4, super cheap. Okay, now it is important for people don't have depression often in a vacuum. It's often they have depression and diabetes, depression and hypertension, depression and high cholesterol, depression and Crohn's disease, depression and acid reflux, heartburn. So the interplay between the depression and their other medical diseases is super important, because it's much harder for an individual to effectively manage their other medical conditions, especially their chronic medical conditions, if they're depressed. One, you just have a hard time remembering to take your medications. Not only your depression medication, you have a hard time remembering to take your medication for your heartburn, or you have a hard time remembering to take your medication for your high cholesterol, your hypertension. So you got to treat the depression. You have a hard time remembering your doctor's appointments. So like, you want people to like actually have their follow-up appointments? Like, treating their depression is an incredibly effective tool to get people to actually like go to their follow-up appointments or have virtual follow-up appointments. Okay. So, and as a result of that, people who are not depressed end up having lower healthcare costs. Their healthcare costs are only about $4,283 a year, whereas people with depression, their average annual healthcare costs are $10,673. Now, it's not like depression causes you to have healthcare costs of $10,000. Oftentimes people have complicated medical conditions, and the stress from those conditions is part of the reason that they're depressed. But the point is that it's silent. It's largely underdiagnosed and undertreated. And so you're like, well, I don't see a lot of depression in my claims. You've got gobs of depression in your employee population that's manifesting itself in heart attacks and strokes and substance abuse and people not having controlled inflammatory bowel disease, all sorts of other conditions that are showing up in your claims are being made worse by the underdiagnosed and undertreated depression within your employee population. So anyway, what's the point here? Common, hidden, minor conditions like hypertension, high cholesterol, depression have major downstream personal and health plan effects. And primary care is the route to screen and treat these, okay? So now, probably the most effective way that employers have done this have been through on-site and near-site clinics. And I would argue that a lot of this can also be diagnosed and treated through virtual primary care as well. And the key is that the companies that typically have these on-site near-site clinics and virtual primary care, they make it at zero out-of-pocket cost for the employees. They make it free. So one of the best ways to increase underutilized care that will save money and save people's lives downstream is to make it free. Should there be parts? Okay, so in other words, it's not the quote-unquote covered at 100% free. There are other parts of care within your employee health plan that you as an employer should make free. It is in your financial best interest to make them free. It is in your employees' best interest to make them free. So and don't be like, oh, we're just going to have runaway. I mean, are people really going to be like, they're not, okay? So when on-site and near-site clinic companies make their care for the employees free, their healthcare costs go down, not up, okay? So it's a highly effective cost containment mechanism to make these things free. Now, I will end with one of my favorite proverbs. You might know this proverb. For want of a nail, the shoe was lost. horseshoe. For want of a shoe, the horse was lost. For want of a horse, the rider was lost. For want of a rider, the message was lost. For want of a message, the battle was lost. For want of a battle, the kingdom was lost. All for the loss of a horseshoe nail. And so as it relates to our talk today, look, the nail is the untreated hypertension, high cholesterol, and major depressive disorder. Then it goes, okay, maybe some chest pain. Oh, maybe you're having some ER visits for the chest pain. You know, they don't really find anything. It's actually fairly common for that to happen. Send you home. Oh, looks like you had a heart attack. Oh, looks like you have another heart attack. That's a massive one, and you have an ICU stay. That's what shows up on your claims, the battles. And then you have poor employee health. You have, rising healthcare trend. So here you are seeing the battles and the kingdoms when you really got to treat the nail up front. And so with that, there are all the sources. Again, if you want the sources, just email me and I'll send them over to you. I will go to your questions now if you guys can stay a few minutes over. If you'd like to connect with me on LinkedIn, please do so. If you would like to join my A Healthcare Z video email list, just email me at ericb@ahealthcarez.com. I'm also on YouTube. If you subscribe to the A Healthcare Z YouTube channel, it's literally tens of thousands of people. It's like 42,000 people across LinkedIn and YouTube are like daily getting access to this stuff. So if you'd like to be part of that 42,000, please either email me, connect with me on LinkedIn, or subscribe to my YouTube channel. Now, with that, let me go to your questions and comments. Thank you so much for putting them in here. And I'm going to kind of try to go back towards the top. Okay, so what laws should be changed? Chad, thank you for your question. It's a good question. Okay, I would argue that the best way to change laws as it relates to healthcare is actually at the state level, because there you can actually get some stuff done. So, and I'm also a pragmatist in that I would actually see, and state legislators are actually very easy to access. So like in terms of like being able to actually talk with your state legislator, like they're actually pretty easy to get in touch with. And then two, it's oftentimes good to find out what sort of legislation they've tried in the past or that they're talking about, because it's instead of, starting something from scratch, it's good to kind of piggyback off of like what is already like in discussion. So start small, start local, start with what's already on the table would be my suggestion. Just my opinion. Okay, next. From Soabib, would love to see how plans reward a plant-based diet for patients that follow a good diet, since that would lead to good cardiovascular and preventive health. So that's a great question. What some employers have done practically is they have provided free food for their employees, specifically lunch. And I've talked about this before, where an HVAC company in Jacksonville, Florida, actually has a kitchen. They built a kitchen in their office and they make healthy lunches, plant-based lunches for all their workers who are going out in their trucks, because they found that they were just stopping at convenience stores and eating junk for lunch every day. And they're like, we got to change that. So they give them free food. Other employers also have a chef and a kitchen where they make them free food at the end of the day that they can take home for dinner. So certainly the U.S. food supply in many respects has been poisoned, but there are things that employers can do to get their employees to eat more healthy. Again, I hate to say it, the key is free. All right. And again, Dr. Dominguez, thank you. Laura Sartan, HCTZ is a godsend and is first line. It's generic. Excellent point. Brian, some grocery store chains offer these meds at $0 as a loss. Right. Again, free. People understand free. Free is, it's amazing. The difference between $1 and free is huge. The difference between $4 and free is huge. People love free stuff. Okay, I'm keeping going through here. Thank you for your questions and comments. I'm still going through. Thank you for your patience. Okay, this is from an anonymous LinkedIn user. Thank you so much for bringing up depression. Our youth has suffered so much along with only 15% with or without healthcare issues are transitioned to adult care. You have no idea the questions these kids have if only someone would ask other than their parents and caregivers. That's right. So, many people who are teenagers, they're obviously entering the workforce in the not so distant future. And so to be able to address so much of the mental health challenges that they've experienced as teenagers is an opportunity that employers have, that if they don't address it, it'll show up in their claims. And with that, I will bring it to a close. If I've missed some other questions and comments here, I will answer them in writing. But with that, I want to thank you all so much for joining A Healthcare Z today, and I hope you have a fantastic day and a great weekend. Until then, we'll be here again next Friday, 8 a.m. Central. Thank you so much. Bye now.